Hi everyone, you're listening to MOHIvate. I'm Dr. Mohi Sarawgee, a GP by profession, curious like all of you, and constantly on a journey of hope. But here, I'm swapping prescriptions for perspective. Today's episode is about tests: what to order, when to order, how doctors think, and why investigating everything isn't kind. Above all, why your story matters most. By the end, I hope you'll feel calmer, more confident, and a little lighter when a lab report lands in your inbox. So let's begin. Maybe you've done this yourself. Your blood results land in your inbox and your heart does a tiny somersault. Numbers, arrows, some green, some red. You zoom in and think, should I Google it? Call a friend? Move to the mountains? Maybe you text a doctor friend or book with your GP. But meanwhile, your heart is pounding. Is this bad? I get it. Results can feel like they are shouting at you in bold red ink. But here's the secret: tests don't diagnose by themselves. They are not crystal balls, they are questions. And questions need stories. By story, I don't mean a 5-chapter medical autobiography. I mean, why was the test done? What symptoms did you notice? And when did they start? What are you worried about? What's normal for you on an ordinary Tuesday? That's the part only you can bring. The lab results can't. Because a result that looks off can be perfectly fine once we know the context: your age, medicines, symptoms, last week's cold, your training routine, and more. Remember, context turns numbers into knowledge. I think of tests like puzzle pieces: useful, sometimes life saving, but only when you can see the picture on the box. Without it, a single piece looks dramatic. With it, it's just blue sky. No panic required. Breathe. In third year medical school, we had a subject called medical semiotics, one of my favorites. It's the language of signs and symptoms, that means medicine before machines. During our exam for the subject, each of us was given 2 patients. No lab slips, no scans, just history and examination. We had to talk through what we found and reach a differential diagnosis just from the story and the patient in front of us. My first patient, I had something sensible to say. The second, not so much. He was elderly, spoke very little English. I spoke very little of his language. And half an hour of careful questions and a full exam later, I still felt very third year, like I had nothing. I remember thinking, this can't be normal. Exams don't do normal. I was already worried I might have to resit, cutting short my summer holiday. At one point, not embarrassed to admit, I even folded my hands in front of him as if praying, "Sir, could you please tell me your diagnosis so I can pass?" He didn't budge. Then came the viva. My professor, kind as a lighthouse, said, "Head to toe, step by step, show me what you see." So I started from the crown and worked down, describing what felt like my own failure. She listened patiently, then leaned in and said gently, "Feel the pulse and observe the neck." I took a breath, held the patient's pulse, looked again, and there it was. So small I'd missed it before. A rhythmic nod of the head with each heartbeat. "Good," she smiled. "Now tell me what that means." And suddenly it clicked. This was Demuse's sign, a rare finding associated with a condition called aortic regurgitation. That's when one of the valves in the heart doesn't close properly, so blood flows backwards. Now you could argue, hang on, wouldn't this also cause a murmur you'd hear with a stethoscope? And yes, it does. But remember, I was a third year. All I really heard through the stethoscope back then was something between a whoosh, a whoop, and sometimes just a polite sort of nothing. Now, this isn't something to self diagnose at home, and in 15 years of practice, I've never seen it again. Every condition presents differently in every person. But that moment changed me because the lesson wasn't spotting a rare sign. It was this: the body speaks if you're looking. Observe, listen, touch appropriately and carefully. Let the story and examination lead. The patient is the first chapter of the book. Tests are the footnotes. That one encounter rewired how I practice even today, even in virtual consultations in its own way. And maybe I deserve a little credit. I had learned the theory. It just needed a nudge and a kind professor to bring it out. And yes, I did get to spend that summer with my family after all. Quick trivia before we move on. De Musset's sign is named after the French romantic poet Alfred de Musset. He had this condition, and his brother famously described the gentle head nodding with each pulse while they were at breakfast in 1842. It's one of the rare signs named after a patient, not a physician. Romantic poetry and cardiology. Who knew? And that brings us to how doctors actually think. From the outside, it looks simple. A few questions, some typing, a stethoscope to your chest. But inside, there's a quiet sprint. Clues, patterns, a mental shortlist, what we call a differential diagnosis. And with experience, this becomes second nature. It's like asking my mum for a home recipe. As a newbie, I wanted teaspoons and grams, and she'd just smile and say, I don't measure anymore, I just know, I've been doing it for years. At the time, it frustrated me, but now I do the same. You learn to judge by eye, by smell, by instinct, because you've done it so many times. That's how consultations work. Clinical reasoning is the cooking, fluid, instinctive, grounded in training. It's not guesswork, it's ingrained. Training, practice, years of seeing patterns. It becomes automatic. But then comes management, what to do next. That part is in cooking. It's like baking. Because in baking, precision matters. Every gram counts or the cake won't rise. Medicine is the same. Prescriptions, dosages, surgeries, those need evidence, guidelines, and exact measurement. So, consultation is like cooking, story, instinct, experience. Management is like baking, precise, measured, and both matter. And this is why doctors don't leap to tests at the first question. First, we cook with your story and exam. Then we decide if we need to bake with a test or treatment. And sometimes the best ingredient is simply time. A borderline result today often settles in weeks. A tiny, uncertain scan finding may just need watching. That isn't brushing you off. It's keeping you safe and avoids cascades of follow-ups when your body just needed time to declare itself. Of course, red flag symptoms like chest pain, breathlessness, bleeding, unexplained weight loss, or that gut feels different moment, we change the plan, then we act fast. And here's the simple truth. A test doesn't hand you certainty. It shifts the odds. That's what doctors call Bayesian reasoning. Don't worry, no math class here. Think of it as medicine's background music, statistics, research trials, probability, all helping us choose wisely. The key idea is pre-test probability, which means how likely something is before we even touch a test. Let's take a few examples. Car keys. Let's say you've been to the market and you've lost your car keys and you're 99% sure you left them in your bag. Searching the bag is a very good test. But if you haven't driven for a while and you search a stranger's bag on the bus, you'll definitely find things, just not your keys. Same action, very different usefulness because the story was different. Another example. Imagine you have a smoke alarm at home and the alarm rings. It could be fire, could be toast. If there's smoke and dodgy wiring, you take it seriously. If you've just made breakfast, it's probably toast. What that means, if fire was likely already, the alarm means a lot. If it wasn't, that positive might just be toast. So we confirm before acting. Let's take one more example. Pregnancy tests. Brilliant when you've missed a period, which means high pre-test probability. But if taken 2 days after unprotected intercourse, just to be safe, even the best test mostly gives confusion. That's the heart of it. Remember, tests don't hand you truth. They shift the odds. If something feels off, tell your doctor the story first. Then we'll discuss if a test helps. A good test at the wrong time gives bad answers. The right story, the right time, the right test, that's when medicine sings. Now that we've seen how tests shift probability, let's meet the troublemakers, false positives and their cousin, overdiagnosis. A false positive is when a test says something's wrong but nothing harmful is actually happening. And false alarms rarely travel alone. One test triggers another, then a scan, then maybe a biopsy or referral, and weeks of worry. We even have a name for it, the care cascade. Let's take an example. We scanned someone's tummy for a genuine reason. The scan was fine for that, but it also showed a tiny cyst in the kidney, what we call an incidentaloma. It's common, it's harmless. Most of us may have one and never know. But once it's in black and white, you can't unread it. Suddenly, follow-up scans, referrals, even a biopsy. Weeks of stress only to end with no action needed. The cyst never harmed. The process did. Another time, someone messaged me about a liver panel. My ALT, a liver enzyme, is slightly raised. Should I panic? We talked, new gym phase, protein shakes, weekend heroics, a mild cold, all yes. Examination, calm. The plan was to hydrate, ease off, recheck level in 8 weeks, and it's settled. The best test here wasn't another panel. It was time with a safety net. Then comes overdiagnosis, the cousin of false alarms. It's when we find conditions that look serious but would never have caused symptoms or shortened life. A powerful population level example comes from South Korea. In the 1990s, thyroid ultrasound screening became widespread. Diagnosis of thyroid cancer shot up more than tenfold. But deaths from thyroid cancer didn't change. Why? Most of what was found were tiny, slow-growing microcancers, the sort people may carry their whole lives without ever knowing. Yet, thousands went through surgery, lifelong medication, scars, and anxiety for cancers that never needed treating. Now, please don't go and do any ultrasound of your thyroid gland. This is just for learning, and this is history. Next, let's look at another example, CT coronary angiograms. They are brilliant if you've got chest pain and we are weighing up angina. However, if used in people who feel well, they may show tiny calcium deposits that might never cause trouble. Once spotted though, they can trigger stents, medications, stress, and cost with little real benefit. The point isn't that tests are bad, it's that more isn't always more. The real win, the right story, the right time, the right test. So we've seen the noisy side. Now let's balance it with some brilliance. When tests are used well, they save lives. Take screening programs, for example. They aren't random, they are chosen because benefits outweigh harms. What actually saves lives? Breast screening. Invitations in the UK every 3 years from age 50 up to 71. Cervical screening. First approach from age 25 to 64 with routine intervals now every 5 years when HPV negative. Bowel screening. The FIT or FIT stool test sent at home. This is in the UK, being expanded to ages 50 to 74. Please check your country's guidelines or speak with your GP to confirm what applies to you and when. They are the quiet lifesavers, most powerful when we simply show up. And then there are the self-checks, coming home to your body, knowing you're normal. Breasts, chest, check for new lumps, skin dimpling, nipple changes, discharge. Testicles, look for lumps, swelling, heaviness. And men, please check your breasts too. Everyone has breast tissue. Check your skin, moles changing size, color, shape, rashes that don't heal. Your bowels, bleeding from the back passage, persistent change in bowel habit, unexplained weight loss, ongoing pain that doesn't settle. And this isn't CSI bathroom edition, not a daily hunt. Just know your baseline and notice when the story changes and then see your doctor. A quick word on private MOTs. If you've had one, no judgment. Bring the results and your story to your doctor and we'll make sense of them together. But be cautious of packages that promise endless tests or certainty when you feel well. Broad, untargeted checks can often spark false alarms and trigger care cascades. And those multi-cancer blood tests, exciting signs, yes, but the research is still ongoing. They don't replace approved screening programs and they are not shortcuts to certainty. Remember, full body scans are brilliant for airport security. For the rest of us, context comes first. And then, of course, there's social media. You've seen the reels. If your doctor cared, they'd check magnesium. The most important test in PCOS your doctor won't tell you about is insulin. One blood test will reveal everything. All slick graphics, persuasive, but incomplete. Take the common example, insulin in PCOS or polycystic ovarian syndrome. PCOS is linked with insulin resistance. However, measuring insulin directly usually doesn't change the management plan. Whether it comes back high or normal, we are still talking lifestyle support, managing symptoms like irregular periods or acne, and sometimes medication. And here's the bit I need you to understand. Chasing the number adds confusion, not clarity. And every test has a ripple effect. A borderline result can trigger referrals, repeats, and worry when you're otherwise well and okay. So the key question is this: will this result change my management plan? If not, think twice. And here's what we do as doctors. Before we click order, most of us quietly run through a few questions. What are we trying to achieve with this test? What diagnosis are we weighing up? The differentials? If the test is positive, what next? If it's negative, what then? If it's uncertain, do we repeat or simply watch with a safety net? If none of those parts would change the plan, we don't order it yet. Curiosity is lovely, but care is kinder. And here's your reassurance. Doctors aren't anti-tests, and we aren't blindly pro-tests. We are pro-you. Tests save lives, but they are not the first step, and they are not the whole step. When story, timing, and test align, that's when medicine works best. So next time, if you feel tempted to test shop, pause, share your story, let us listen, examine, and then if needed, test wisely. If you remember just one thing from today, let it be this. A good test at the wrong time gives bad answers. The right story, the right time, the right test, that's when medicine finds its meaning. And don't forget the quiet heroes, the self-checks and your screening invites. They save more lives than the trendiest test online. I hope something today stirred a thought, gave you a smile, or simply made you pause. Whatever time it is where you are, I hope you carry a little feel-good factor with you. Thank you for listening. I'm Dr. Mohi. Until next time, stay motivated. May your tests be meaningful, may your stories be heard, and may your body always feel like home.